Hey, welcome everyone. Thanks so much for joining us for this research showcase. And so this is presented by the Lifestyle Medicine Health Research Centre. My name's Darren, I'm the director of the centre, for those who don't know me. And I'm really excited because we've got 4 presenters today, and we're going to launch straight into it because I want to give them as much time as possible. But we have 2 of our presenters actually who just completed their confirmation this week, which is fantastic. So we'll have Michelle and Hannah. And they're working under the care of Professor Brett Mitchell and doing some great work in that space. So you'll get to hear more about their projects. And then our final 2 presenters, Gemma and Di, are undertaking major projects in the Master of Lifestyle Medicine program. And they've got some great projects as well. So I'm sure that you're going to enjoy hearing about the work they're doing. If you've got any questions as we go through, feel free to put that in the chat. And if we've got some time at the end of each presentation, we've got about 10 minutes for each presenter. So if we've got a bit of time, we'll throw a question there too. But so nice to have you all here. And yeah, I'm sure that you're going to enjoy this. And Michelle's going to kick it off for us. So thank you, Michelle. Feel free to share your screen.
Okay, thank you.
Bye.
All right. Okay. So thank you very much. Yeah, I did my confirmation presentation yesterday, so that was exciting. And so I can talk about this for hours, but I'm just cutting it down to 10 minutes. So yeah, so thank you. So my name is Michelle Chalker. I'm one of the lecturers at Avondale Nursing. So I am a registered nurse. I've worked clinically nursing. I've worked as an infection prevention and control coordinator. I've worked in international public health, and I am a part-time nursing lecturer and doing my PhD full-time. So it keeps me busy. So my PhD is titled Surveillance and Impact of Non-Ventilated Healthcare-Associated Pneumonia, or NVHAP, in Australian hospitals. And I will be doing my PhD by a publication. All right. Some background. Healthcare-associated infections, or HAIs, are infections that patients acquire when they are in the hospital. So they don't have them when they come into hospital. They get them specifically while they are patients in the hospital. So I looked at some studies, and there was 2 particular ones I want to highlight here. One was from Australia and one was from in the United States. And in these studies, they were looking at what HAIs were in patients in these hospitals. And there were 12 that were identified, 12 different types that were identified. But I just want to highlight, and this highlights a particular gap for this research, is that the most common ones were a surgical site infection, pneumonia, urinary tract infection, and gastrointestinal infection. Now, within Australia, it is mandatory for hospitals to do surveillance and to report data on certain HAIs, but there are only 4 HAIs for this. And as you see here, that pneumonia was one of the most common in Australia and in the United States, but it is not one of the HAIs that Australia has mandated that we need to collect and monitor. So that's a problem. Healthcare-associated pneumonia, or HAP, refers to respiratory infections which are associated with receiving healthcare. Now, there are 2 subtypes. There's a ventilated-associated pneumonia, VAP. It's defined as pneumonia, which was not present when the patient was admitted to hospital, but they have acquired this pneumonia when they are receiving mechanical ventilation to support their breathing. So we've got then non-ventilated healthcare-associated pneumonia, NVHAP, refers to pneumonia, again, not present when the patient was admitted, but they acquire it in the hospital. But the difference between this one is that they can breathe on their own. They haven't had to be supported by a ventilator. So for my research, I'm just going to be talking about NVHAP. All right. Why do we collect disease surveillance? Why is that important? We want to collect it because we want to know how many people actually have this, infection or disease? Is there identifiable population at risk? Are we doing anything to prevent this within the hospital? And if so, is that actually working? Okay, and as I've said, we are not collecting this data in Australia. All right, now we've got a disease definition is a really important part of surveillance. So in healthcare and research, to be able to identify that a person has a particular disease, so in this case, NVHAP, there should be a mutually agreed upon throughout the world definition, and that definition would include signs and symptoms, lab results, pathology results. But for the case of NVHAP, there is not one mutually agreed upon definition. There's actually 4 definitions that are being used throughout Australia. So the issue with that is that we may not be collecting, or we may be missing patients that have actually got NVHAP. There's a final way that we can do infectious disease surveillance, and that's using administrative coding data. So when you go into a hospital, if you go in for a broken leg, as an example, you get coded for a broken leg, and that coding is used for financial reimbursements for the hospital. But using administrative coding data is not known to be an effective way of infectious disease surveillance. Okay, what's the impact? So if you have a diagnosis of NVHAP, the current research is showing that this can lead to a median, an extra 16 days of staying in hospital. Okay, so what? What's the problem with that? The issue with this is that the longer you stay in hospital, the higher the chance that you're going to get a hospital-acquired infection. Simple as that. Also, that means that the patient is not going back to work, not financially or emotionally supporting their family. Okay. But a big issue that's been identified with NVHAP is that it leads to death. So it just being diagnosed with NVHAP, that leads to, in this one study, 22% of those patients die due to NVHAP while they are in hospital. And hospital-acquired infections, and NVHAP is one of them, are actually preventable. So this is something that we need to do something about. I've got 4 aspects of my study. One is a systematic review, which I have started. The first study is looking at the incidence and risk factors for NVHAP. The second is looking at the impact of NVHAP on prolonging length of stay and ICU admission. And the final one is the impact of NVHAP on inpatient mortality and identifying risk factors. I've got 4 overarching aims, looking at the incidence and risk factors, looking at the accuracy of a particular surveillance definition to see how accurate that is, looking at how much NVHAP prolongs a person's length of stay, and also determining the impact of NVHAP on inpatient mortality. I've got a few different methodologies. Study 1 and 2 are going to be done using a cohort study. So this is fairly typical for this type of epidemiological study. A cohort study looks at exposures and outcomes. So for this study, the exposure is simply being admitted to hospital, and the outcome is being diagnosed with NVHAP. Study 3 will be a matched nested case control study. So the cases are the participants that have been diagnosed with NVHAP, and the controls are participants that haven't been diagnosed with NVHAP. So this case control study is nested within the cohort study, and we're going to match cases and controls. So it's probably going to be a 1 case per 3 controls, but that's going to be dependent on how many cases we identify. And in this study, it's going to be matched on age and sex and comorbidities, which are additional medical diagnoses. It's going to be in 2 hospitals in New South Wales, one public and one private. It's going to be a retrospective data collection, so it will be at this point in time, January 2025 to the end of June, and I will be collecting from looking at a week behind. This is the plan so far. We're going to look at populations that are participants, potentially that they're over 18 years old, so they're adults. They need to be admitted for 48 hours or greater. 48 hours is because that's the time measurement for it to be a hospital-acquired infection. I've got exclusion criteria, and the big ones are the last 2 at the bottom, that the patient is not admitted or suspected, admitted with a community-acquired pneumonia, or they haven't been on mechanical ventilation and ICU, so that would be ventilated associated. So they can't have any other pneumonia being suspected or being diagnosed. Data collection, there'll be one very large data collection for the 3 studies. I'm going to be looking at medical records for these patients and looking at their administrative data and clinical data. It's going to be captured using REDCap, using specific data fields. We're consulting with the statistician at the moment for looking at an appropriate sample size that I can achieve by myself within 6 months. I've identified gap. We don't know. So there is one study that was done in one rural Queensland hospital that looked at certain aspects of NVHAP, but we don't have a broader view of NVHAP in Australian hospitals. So that's the gap for here. So looking at the incidence. We're also going to look at the accuracy of a particular NVHAP definition for surveillance. I'm going to look at how NVHAP actually prolongs a patient's length of stay, and then maybe some risk factors for those. I'm going to look at information about how a diagnosis of NVHAP impacts inpatient mortality. And then finally, I'm going to look at the risk factors associated with prolonging length of stay and inpatient mortality. That's it. And I can chat for days on that.
All right, thank you so much, Michelle.
You're welcome.
Actually, it's the first time I've been able to have a bit of a deep dive into what you're doing as well. But yeah, just such important work. And yeah, you've just got a couple of affirmations there coming up in the chat. What I love about these kind of initiatives, and this is sort of characteristic of all Brett's led projects, is that the potential for them to have real impact and translate into some really meaningful outcomes for
and really the impact of this will actually in the future help save people's lives and prevent them from getting this disease, which is actually preventable in most cases. So it is very impactful for the future for people admitted to hospital. So it's exciting. I'm looking forward to finding results.
Fantastic. We look forward to hearing them. Hannah, you're up.
Thanks, Darren. Thanks, Michelle. Okay. Are we all seeing my screen there?
Yeah, we're good.
Perfect. Excellent. So hello, everyone. My name is Hannah Kent. I'm an associate lecturer here at Avondale University, a critical care registered nurse, and a full-time PhD student. So this photo actually signifies the first time that I wrestled with my chosen PhD topic about 9 years ago as a nursing student. And Avondale Marketing had come down to the Sydney campus and asked my friend and I to enact a nursing procedure. And we decided that aseptic technique would be a great procedure to act. And if you haven't noticed already, I am the patient in the bed. And I still vividly remember the conversation with my friend at this moment. And we were both questioning, are you supposed to be wearing gloves right now? Is this the correct technique? And this was actually the first time throughout my professional career where I observed confusion around the correct method of aseptic technique. Now, when I initially explored this topic, I wanted to look at how we taught aseptic technique to undergraduate nursing students. And to inform my teaching, I thought, okay, so I need to figure out what is actually the correct method of aseptic technique. And what I discovered is that there was quite a bit of variation in the literature, and there was a lack of empirical evidence surrounding the correct technique. And so I decided to explore this method of aseptic technique actually in the clinical nursing setting. Now, just as a bit of a background, this concept of asepsis originated from Joseph Lister's work back in the 19th century. And essentially, he discovered that infections could be prevented by avoiding the contamination of surgical wounds. Now, there are quite a few variations in the definition of asepsis, but essentially most definitions describe it as the freedom from all pathogenic microorganisms, which is disease-causing bugs, essentially. And this concept of asepsis has been extended to many various medical and nursing procedures over time outside of the operating theatre environment. Aseptic technique is a method to achieve asepsis, and it has been characterized and described in literature in various ways. It's been described as a method, a procedure, a practice, a process, and this technique is used in many nursing procedures. You might be familiar with this blue dressing pack over here for our wound dressings, but it is also used for other nursing procedures such as the insertion of intravenous cannulas, indwelling catheters, the manipulation and maintenance of central venous access devices, and the list goes on. Aseptic technique is a foundational element of infection prevention programs, and it is imperative in reducing healthcare-associated infections like our surgical site infections and catheter-associated urinary tract infections. And so this technique ultimately does ensure patient safety by preventing infections. Now, when I looked at literature, I came up, or I've kind of thought of these, discovered these three main issues. And the first one is actually the variation in guidelines and literature. Now, there is a lack of consensus surrounding the definition and the implementation of aseptic technique in our clinical nursing settings. And this has led to the emergence of various terms in literature over time, such as a sterile technique, a clean technique, and a medical aseptic technique, etc. And these terms tend to be used interchangeably. And when I looked at the Australian guidelines and recommendations for aseptic technique, I actually realised there was a national variance, and it varied from state to state, and it actually varied from local health district to local health district. Now, this issue isn't actually specific to Australia alone. It is an international issue as well, and there is international variance. And that's demonstrated by this paper that was published by Purcell and colleagues, and he highlighted the difference in the international differences regarding what techniques were actually recommended to undertake procedures that require asepsis. And you'll see on the side here, there's 16 different organisations on this heat map, and down the bottom is the kind of the different methods. So, for example, if you look at Australia, the black box included, it says that it's included in the recommendations. The white means that it's not. And in the Australian, we're going to go to the gloves, and you'll see that gloves aren't necessarily recommended for all procedures that require an aseptic technique. And then you head up to the Northern Ireland at the top, and they recommend that you use gloves for aseptic technique. So you can see that no two organisations and governing bodies actually can agree on what the correct method of aseptic technique is. And this relates to confusion in clinical practice. And I kind of deduced that we've taken this very concept from a controlled environment, such as an operating theatre, to our ward-based environment, which is a semi-controlled environment. And sometimes, if we're looking at our community settings, it's an uncontrolled environment. And this has led to the confusion among nurses. Now, there was a survey completed in the UK, and it did reveal confusion around that nurses were confused about the definition and the principles of aseptic technique. Unfortunately, only 46% of these nurses could actually identify what the principles of aseptic technique were. And they also identified that they needed a standardized approach to this technique. And we've got challenges in education as well. And unfortunately, sometimes our educators in the clinical and tertiary settings inadvertently encourage staff and students to essentially rote learn the skills that require an aseptic technique, instead of actually applying the principles of aseptic technique to the procedure. And Hawker, who has done some preliminary work in the UK regarding this topic, did a national survey of 49 UK universities, and it did show significant variations in the teaching methods and the principles of aseptic technique. She actually asked the educators, so what do you deem to be the principles of aseptic technique? And collectively, they all came back with 40 different responses. So there is a clear, well, I shouldn't say clear, but there is a confusion surrounding the principles of this procedure. And that leads me to the clear gaps in literature. So the specifics of what, when, and how aseptic technique is incorporated into clinical nursing practice outside of the operating theatre remains relatively unknown. And there is a lack of empirical evidence and consensus on aseptic technique principles. And within the Australian, we need to know within the Australian and New Zealand context how our nurses understand and apply aseptic technique, because you will see that all the evidence I've pulled is actually from the UK, and there's very limited evidence in our current context. So in light of these gaps, the overarching aim of my thesis is to explore a principle-driven approach to aseptic practices conducted by nurses. I have three main study questions. So the first is, how is aseptic technique defined and applied in clinical nurse settings? How do nurses understand, recognise and apply asepsis? And actually, what do a panel of experts deem to be these core principles of aseptic technique? So a multi-method approach will be used to conduct this research. As I've mentioned, empirical evidence on this topic within the Australian and New Zealand context is limited. So therefore, the approach of this project is to actually have a series of phases to inform subsequent phases of my program of work. And hopefully this will create a body of evidence that has the potential to inform future interventions. Now you see that phase one is a scoping review. So I'm just mapping the breadth and the depth of the literature that's out there regarding this topic. My second phase is a cross-sectional study, which will be surveying our Australian and New Zealand nurses to try and actually articulate this problem in our context. And the final phase is the Delphi study. So I will be drawing on the expertise of a panel of experts in this field to hopefully gain consensus on what are the core principles of aseptic technique in our clinical settings. Now, the outcome and impact of this study. So the outcomes of this study has the potential to inform the development and validation of a principle-based framework for aseptic technique. It has the potential to impact education as it will provide an evidence-based framework for consistency across our educational institutions. It will impact clinical practice, but ultimately it will impact our healthcare systems, hopefully lowering the risk of hospital-acquired infections, and ultimately it will ensure patient safety. Now, some of you might be familiar with this infographic here of the 5 moments of hand hygiene. My absolute dream would be to create an infographic like this of a standardized approach to the 5, 7, 10 moments of aseptic technique. So it's accessible to all our nurses, and hopefully it could potentially be used as an auditing tool as well. So thank you for listening, and I will hand back to Darren.
That's fantastic, Hannah. Once again, just a really, really important and needed project. So it's really, for me, you know, that where research is meaningful is when it actually is going to translate to some, you know, to influencing people's lives in a positive way. So So yeah, once again, some nice comments coming through. And if you got any questions, feel free to share them in the chat section. But thank you, Hannah, and thank you, Michelle, for the work you're doing, and congratulations on getting through your confirmation. And we look forward to updates on as your data collection starts to unfold. So our next two presenters are very courageous. I'm going to start by saying that because they're not doing a PhD, they're doing a major project as part of their Master of Lifestyle Medicine, and they only commenced this in the middle of the year. And to both of them, I said, "Hey, we've got this research symposium coming up. You could present this idea for your research project." And they were both courageous enough to put their hand up and say, "Yes, that I'll do that." So thanks so much to Gemma and Di. So I'll hand it over to Gemma first of all. And Gemma, I think you've got you'd like to share your screen.
Yeah, I'll do that now.
There we
Hello,
go.
everyone. No, thanks for the downplay, then, Darren. Because honestly, I've been sitting here thinking, oh, wow, I'm not really up to this level of what everyone else is doing. But anyway, here we go. So I'll just bear with me while I figure out how to get back to my start. See, already I'm unprofessional. Sorry, everyone.
No,
Okay.
you're doing well. You're doing well,
From
Gemma.
the beginning. Hello, my name is Gemma Skelton, and I'm a pharmacist. And I've actually been in pharmacy pretty much my whole life. I know that sounds weird, but my mother and my grandmother owned pharmacies. So it's pretty much the only job I've ever had. They owned pharmacies around the Lake Macquarie region. And so really, this is kind of what spurred this lifelong interest in healthcare to start pursuing my Masters of Lifestyle Medicine. And I currently split my time between working in a community pharmacy and working as an on-site clinical pharmacist in a nursing home. So I know what you're all thinking. Pharmacists just hand out pills, right? Well, honestly, that's just only part of the story. And the best part of my job isn't the medicines, it's actually the people. And I love helping my customers get the most from their meds and setting them up on a path for better health. And that is what really has sparked my deep interest in lifestyle medicine, helping people not just manage their conditions, but truly live their best lives. So today, what I want to talk about and explore is this big question: can community pharmacies act as a bridge between online mental health programs and the community? So before we dive in, let's talk about what positive mental health really means. And according to the World Health Organization, it's the ability to recognize your strengths, cope with life's challenges, work productively, and contribute to your community. Sounds pretty ideal, right? But unfortunately, in Australia, 1 in 7 people are prescribed antidepressants, and over 3.5 million prescriptions are dispensed each year. Now, that's a lot of little boxes. And that actually puts Australia among the highest globally for antidepressant use, which, as you can imagine, comes with its own set of side effects, reduction in productivity, and rising costs. So here's where community pharmacies can come in. With over 5,900 locations across the country, pharmacies are actually the unsung heroes of the healthcare system. And I'm proud to say pharmacists rank as the 3rd most trusted professional in Australia. And the average Aussie visits a pharmacy 18 times a year. So we're practically your local friendly neighbourhood health advisor. And most of us here would live within 2.5 kilometres of a pharmacy, and making these trusted spaces perfect spots for promoting mental wellbeing programs. So our research will focus on offering the LIFT project through community pharmacies. For those of you who aren't aware of the LIFT project, it is an evidence-based 10-week online program that's all about improving mental wellbeing. And participants can move at their own pace with weekly lessons, and it's either a written version or a video online, with fun challenges to keep them motivated. Plus, we'll send out weekly emails just to keep them on track. So the idea of our research project is we're aiming to see how well pharmacies can promote and recruit mental wellbeing programs in their pharmacies. And that's either through their online social media platforms, in-store catalogues, or just chatting with the staff. And we'll measure how many people join in, their satisfaction with the program, and how helpful they found the support from pharmacy staff. We'll also look at how comfortable people feel with getting wellness advice from their pharmacist. And we'll see whether or not they'd recommend this program to their friends, because let's be honest, the best way to see if something's working is how positive people talk about it. And our trial will take place in Cessnock, which is a large rural town in the Hunter Valley, with actually sadly higher than average rates of anxiety and depression. And we're partnering with Cessnock Plaza Pharmacy and Cessnock Day Night Pharmacy. And I feel like the advantage of using the two stores would be the extended opening hours, so participants can engage with pharmacy staff whenever it suits them. And both stores will have interactive websites where they can book appointments online to book in with a pharmacist in our private consulting rooms during the day. Okay, so to wrap things up, I truly believe that community pharmacies are in a unique position to lead the way in promoting mental well-being. With their accessibility, trusted relationships, and personal connections, pharmacies can offer more than just medications. They can provide hope and empowerment. By integrating programs like the LIFT project, we can help individuals manage their mental health in a way that goes beyond medication. And as we move forward with this trial, I'm actually really excited to see how pharmacies can evolve to better serve the mental health needs of Australians. And I'm hopeful that this model could be the blueprint for wider adoption across the country. And together we can help people live their healthiest and happiest lives, one interaction at a time. Thank you, and that's me done. Sorry, it was a bit rushed at the end then, wasn't it?
That was brilliant, actually. So well done. Once again, just to give you some context, literally both Gemma and Di started in the middle of this year. So this has been the idea of the formulation of a research project. You've done a great job. That's exceptional, Gemma. And you know what? It's actually been really educational for me to understand the role that pharmacies do play in, meeting and addressing the health of the nation, really, in terms of their scale and their accessibility. So, thank you, Gemma. Fantastic. And I'm really excited about this project and the potential for impact as well. So our final presenter is Di, and I'll just say a couple of words about Di. So Di has actually been doing, I don't know when she started the lifestyle medicine program. Di, you
about a decade ago.
But Di, and you'll hear a little bit of Di's story in this, but Di really is a remarkable person and actually won an Order of Australia medal for the work that she's done. And I won't steal her thunder, so I won't say much more about that. But has really had a very large scale impact on particularly the health and well-being of women, but in the process found out a way to raise very significant funding for projects that count, like Beyond Blue and the Fred Hollows Foundation. I think it's up to like $50 million or something that you've...
Yeah, we've just passed 50 million. Yeah, it's pretty cool.
So it's really, really great. So anyway, we're looking forward to what you're about to share with us. Thanks for being with us, Di.
Thank you very much. And what Darren didn't tell you was, I don't think Gemma and I had a choice. I think we just, just want to say, I don't think I was putting my hand up for this. But anyway, I've chosen not to do a PowerPoint presentation, but I am going to show you a little video. But I'm just going to give you a little bit more of my background just to put things in context. So I have been a passionate advocate of health and fitness all my life. Having been a national gymnastics champion at 16, then studying physical education, spent years in the fitness industry, then went back to university and studied journalism and dabbled in that for a while with young children. But 20 years ago, I started my own business, and the goal of the business was to get women into the outdoors and get them fit for extreme challenging adventures around the world, things like trekking up to Everest Base Camp or climbing Mount Kilimanjaro. And for the first probably 5 years of that business, I wasn't able to work out how to pay the rent. So it was a little bit of a sad time in my life, but I pushed through and then created a program, an event called Coast Trek, and it was Coast Trek that allowed me to share my passion with tens of thousands of women, and that passion for getting them outdoors, helping them rebuild their confidence, getting them physically active and connected with other women. So it was an obvious choice for me, having spent 8 years ploughing my way through lifestyle medicine while running a small business. It's very exciting that I've now got to this kind of little tipping point where I can actually devote some time to really looking deeply into the mental health benefits of the COSTREC program. So I'm just going to put a video on just for those of you who aren't familiar with COSTREC. Has anyone done COSTREC, by the way? No. Okay, so let me just show you a little bit of what it looks like. Can you see that? So that's a little bit of a taste of what you'll get when you all sign up for COSTREC, because I know you will after this. You're going to love it. COSTREC appeals to midlife women. So with Darren's help, we've sort of crafted the study to look at the influence of a community outdoor hiking program called COSTREC and on the mental health and well-being of peri- and post-menopausal women. So just to quickly give you a little bit of a background in this area, as Gemma's already highlighted, we in Australia have a significant problem with our mental health, and women fare worse than men in that area, with higher rates of psychological distress, anxiety and depression than men. In fact, in 2022, 24% of women reported a mental health disorder, so a quarter of women really struggling. And peri- and postmenopausal women have a double whammy because things get worse for them in many instances. So there is a reported increase in mood disorders, anxiety and depression for women in peri- and post-menopause. And all of this leads to a general trend of 71% of GP visits are for mental health. And as many of us will know, these are commonly treated with pharmacology and psychotherapy. But there's increasing evidence for the benefits of lifestyle medicine. So the lifestyle medicine is not only shown to be linked to prevention, treatment and cure of psychological distress, stress, mood disorders, anxiety and depression, but also to assist in flourishing, increased quality of life and general well-being. And this evidence includes peer-reviewed studies, anecdotal evidence, randomized controlled trials and research panels. So it's quite a significant body of evidence, very compelling. And more recently, this is not a large body yet, but I think it will be, evidence specific to peri- and post-menopausal women is starting to emerge. And they do have some specific characteristics that reflect that time of a woman's life. So the evidence supporting the links between mental health and lifestyle medicine are based on a number of pillars. And for my study, I'm looking at the pillars of lifestyle medicine that are most impacted by the COSTREC program. And that is physical activity, social connection, nature, not just nature, but where green meets blue. So the beautiful benefits that we get from being near the ocean, near water, and also all of those wonderful therapeutic benefits from being in the forest and in the green spaces. Social connection, I've mentioned, adventure. This is one that's not a typical pillar of lifestyle medicine, but it certainly has a lot of evidence behind it, linking it with positive mental health and well-being, increased confidence, etc., and also purpose. And I've added purposes, although again, not one of the main pillars of lifestyle medicine, very relevant to well-being, positive psychology, and the particular purpose I'll talk about with COSTREC beyond health and fitness is the fundraising. So what I would like to investigate is, whilst the COSTREC program and event is not traditionally or not currently considered a lifestyle medicine intervention, and much to my disappointment, my local GP, despite knowing about it for 20 years, has refused to even mention it to her patients. But what I'm curious about is that there's many other outdoor community physical activity programs that draw from these pillars, and what influence they may have on people's mental health and well-being, particularly peri- and postmenopausal women. So just to give you a little bit more detail about the COSTREC program, what you saw in that video was obviously the event day, but what leads up to that is a 12-week online training program with weekly emails, a little bit like the LIFT project, where we provide our COSTRECers with information on how to train, how to prepare, everything that they will need for the event. It encourages them to form their teams of 4, and the teams will then get together training 3 times a week. We give them a very comprehensive training program, and basically try and hold their hands every step of the way, so that when they get to their event day, they're very well prepared and they have a fabulous time rather than the opposite. And we do get a few that don't do the 12-week training program, but certainly those that do say that that's actually their favourite part, even more than the big 20 to 50 kilometre hike. And those hikes take place on spectacular coasts around Australia. You would have seen in the video our locations. So the special need for peri- and postmenopausal women comes around increasing rates of mood disorders, anxiety and depression, and also increased barriers to participation in physical activity, including things like time, safety, cost, confidence, transport, childcare responsibilities, and also, interestingly, fear. We have found that peri- and postmenopausal women have a lot of fear of being outdoors and being in the bush. So a particular need there. The other thing I wanted to touch on with regard to purpose is that we require our COSTRECers to raise $500 per person as part of their participation, and we give them help along the way with that also. Over the 12 weeks, we give them suggestions and ideas and tips and tricks on how to raise that money. Most of them ask their friends to donate to their cause, and we found that the longer the distance they're walking, the easier it is to get that donation. And over the years, we have partnered with the Fred Hollows Foundation, as Darren said, currently the Heart Foundation, and also with Beyond Blue. So of those, obviously Beyond Blue is the most natural fit for COSTREC, and our 2025 series of events will be with Beyond Blue. And to date, over 80,000 Australians, mostly peri- and postmenopausal women, have participated in COSTREC. So my primary question for the study is, what is the influence of a community outdoor hiking program, COSTREC, on the mental health and well-being of peri- and postmenopausal women? And the reason hiking is such a significant physical activity is that it captures a whole lot of benefits because it is by nature, in nature, and it also allows a variety of surfaces and a variety of benefits for other parts of the body, in addition to obviously the brain. So hiking is it's been described by many experts as a harder version of walking, as being the perfect medicine and the perfect physical activity for overall health. So I'm really thrilled that I've been able to find a physical activity after many years of searching that appeals to large numbers. And I think that's a difficulty with many of the physical activity programs, is that they don't interest a lot of people. But hiking is growing, and walking is the most popular non-sport physical activity for women. So it's really a good space in terms of opportunities to reach thousands of people. My secondary question is, to what extent do the components of COSTREC, including physical activity, social connection, nature, adventure, and purpose, contribute to the mental health of peri and postmenopausal women. The study will involve a survey of over 7,000 participants from the 2024 COAST-TREC program and event. And they are, by the nature of the event, 90% of our participants are women, and 80% of those are in midlife. So that's a very unique cohort, and I'm very excited that I have an opportunity through my business to survey those women. And they will be receiving approximately 25 questions, some open-ended questions, and some multiple choice questions in order to assess their experience of COAST-TREC in relation to mental health and wellbeing. So it will be women 35 to 55, and I will be excluding men, and also women under 35. So I'll be using both qualitative and quantitative techniques. And the significance of the study, my hope is that the research and the results of the study can be used to assist our understanding of how programs could potentially be scaled as interventions, with the opportunity for them to be used not just clinically but in pharmacies. Gemma, wouldn't it be great if pharmacists could add that to their kit of tools? Here's this great program that you can join that will motivate you to get moving, connect with your friends, get into nature, all those good things, and even broader appeal. Perhaps we could get health insurance companies listing this as a wonderful way to support both prevention, treatment and cure of many common mental health disorders. So, yeah, I think that's me.
Fantastic. Thank you, Di. And I've got once again, some great comments coming through. Just amazing. Talking about 80,000 people that you've impacted throughout Australia. Just amazing. And then the fundraising efforts and all of that. So yeah, wonderful stuff. And we really look forward to learning some of the outcomes that arise from it. While we're on the topic of hiking, don't forget Illuminate. I'll give that a plug this Saturday nights here on the Avondale campus, starting at 6 p.m. You can do 5 through to 40 kilometres. So so keep that in mind. But hey, I just want to say a big thank you to our presenters. Honestly, you guys are doing amazing work. I was looking at a comment there from Maria. She was just saying, wow, these projects are so clearly they're research that matters and will impact the world, and that's a fantastic thing. So good on you. There's also a comment, Gemma, just for your benefit, from my brother Jason, who said, "You've enlightened me." Now, while it's not difficult to enlighten my brother, it was an epiphany for him of just how pharmacists can be a front line in addressing the healthcare needs of our population. So, hey, thank you so much to our presenters. Great job, great projects, high impacts, and love what you're doing. Keep up the good work, and we look forward to hearing the outcomes as time passes. Thanks also to everyone who joined us online. If you've got any particular questions, I'm sure the presenters would love for you to reach out to them individually. And if you've got any comments or queries or things that you might think that might be helpful to them as well, then please feel free to do that. And if you need their contact details, direct them to me and we'll be happy to pass them on. Thank you for joining us. Have a great rest of your Thursday afternoon. And once again, thanks to our presenters. Fantastic.
Thank you very much, Darren. Thank you, everybody. Bye.